Hello, everybody. I'm very glad you could all make it here today. It is March 23rd, and today's webinar is Access to Colorectal Cancer Screening and Treatment in Rural Communities. This is a really important subject for our community and all colorectal cancer survivors, because as we talk about different ways that we can address health equity and connecting people to the resources that help them make decisions about their treatment and about how to talk to their families about screening, your location and geography is an extremely important factor in that conversation. We know that a person's zip code can really dictate how accessible their doctors are and those additional treatments may become. So what we want to do is take today and invite Kellie Hoffman, one of our research advocates and highly respected members of our Fight CRC community, and Dr. Linda Overholser from the University of Colorado School of Medicine Anschutz campus to help enlighten us on some more information and resources for addressing this important topic. Before we get started in introducing them, I just want to give you a little bit of extra background on this webinar. We'll have this as an integrated discussion. So you'll hear a couple presentations. Then I also want to invite all of you out there in the community to ask questions. We have a Q&A section that you can address at the bottom, or you can also use the chat function, and we will be able to answer questions for you at the end. We also want to make sure that you know that this webinar is recorded, and you'll be able to see a recording of this in the webinar archive on our website at fightcrc.org. And please also tweet along or message the people in your networking community using social media as we go. It'll help people engage with the subject, and we can get more of this information out there to more people. So thank you very much for that. Also, I invite you to join us at fightcrc.org to look at some of our resources, which includes Wellness Wednesday, which is an online video series that we've done on Facebook Live, as well as Tabooty, our podcast series. We also have a very active blog where you can read on a lot of other topics and similar subject matter to this. Then we also have our flagship resource, Your Guide in the Fight, and all of our mini magazines, which make up the backbone of our printed publications, where you can get really in-depth on a variety of different subjects and topics to help support survivorship for you or your patients. Also, just as an important disclaimer here, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. And Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. Okay, so I want to quickly just give you an introduction to our first presenter here, and then she'll get a chance to introduce herself as well as we bring her on. First today, we have Dr. Linda Overholser, who's a general internist at the University of Colorado School of Medicine and the medical director for the TACTIC, Thriving After Cancer Treatment is Complete clinic at University of Colorado Health. She is also the University of Colorado Cancer Center representative to the National Comprehensive Cancer Network Cancer Survivorship Guidelines panel, where she is also the leading secondary primary cancer subcommittee. Her clinical and research interests are in primary care for individuals with a history of cancer, how to best coordinate that care with oncology providers, and in community engagement for cancer survivorship research. The next after that, we'll have Kellie Hoffman, who's a member of Fight Colorectal Cancer's Research Advocate Training and Support Program and a dedicated supporter of our patient education efforts. She has worked in television news for 13 years and also worked for the Department of Transportation Legal Division, as well as a few law firms. Kellie currently resides in Ona, West Virginia, and her interests include reading, painting, gardening, beekeeping, walking, and raising 2 teenagers with 2 exclamation points, because I'm sure they both deserve one. So, all right, next we will go into Dr. Linda Overholser's presentation. Thank you so much, Linda.
All right, thank you. I appreciate the opportunity to come chat with you all today, and I'm excited to hear Kellie speak as well and have a conversation. So I just wanted to share some of my thoughts, kind of understanding what the agenda was going to be for today. My interests most recently are certainly in survivorship and what happens after a cancer diagnosis. However, I started that. The work that I was doing was around colorectal cancer screening. And from that, I then got involved with cancer survivorship. So I thought I'd just kind of go back and start at the beginning and see, think about where we started or where I started with looking at colorectal cancer screening in Colorado. So I'm just going to give a brief overview of some of the work we've done here with my mentors in family medicine in Colorado, and our experiences and lessons learned. And then certainly survivorship is a part of that, but not the main focus today. And then I'm just going to bring up a few points at the end for thinking points, perhaps for discussion. So my work started, there was work going on in about 2004, 2005, led by a team in family medicine. And for any of you here in Colorado, if you know Dr. Jack Westfall in family medicine, he's a huge advocate of community-based participatory research and is from the Eastern Plains of Colorado. And I have a map there highlighted in red. Those blue counties in Colorado are all designated as health professional shortage areas or medically underserved areas and are considered rural or frontier. And he's from that area, although has been working at the University of Colorado when I met him and he mentored me. And at the time I came to the University of Colorado, he was interested in looking at how can we increase rates of colorectal cancer screening in Colorado, and specifically focusing on rural communities where it may not be as easy to get some of the recommended screenings done. So in brief, this was a project that was already started. It was funded by the Centers for Disease Control. It was a multimodal intervention, again, utilizing those community-based participatory methods throughout. And this was a community advisory council with members from those Eastern High Plains that were really involved with shaping the intervention, learning about colon cancer screening, and then helping develop materials to do the intervention and helping to analyze the results. And these materials included a Spanish language version because in these communities at the time that we did this study, we were looking at the top half of that red shaded area in Northeast Colorado, and there was quite a significant population of workers of Hispanic ethnicity that made up about at least, I think, 15 to 20% of the population. So these are some of the papers that came out of that work. We looked at knowledge, attitudes, and beliefs and personal practices regarding screening among healthcare professionals in rural Colorado. The little side project that I did with this bigger project was looking at the use of colon cancer testing in rural Colorado primary care practices. So it's one thing to look at what the community is doing and what community rates are. This was specifically looking at people who have what we call a medical home or a source of primary care. And does that make a difference in their screening practices? And then there was another paper to come out. There were several papers to come out of this, but these are just a few. And this was a paper looking at predictors of screening in rural Colorado, testing to prevent colon cancer in that High Plains Research Network. So just in the interest of time, I'm just going to go over some of the lessons we learned out of that. And at this time, and I think things have slightly improved, but surprisingly, what we saw in the community was that rural screening rates are pretty comparable to urban colon cancer screening rates, but still much lower than what was recommended. I think the goal at that time was 70%, and screening rates for colon cancer were only about 59%. So there was definitely some work to be done. Some of the strongest predictors of being considered to be up to date with colon cancer screening. So remember, with colon cancer screening, there's getting the test done, but there's also getting it done at regular intervals and making sure that you're not getting one test and then just never getting another test done. So it's a continuous process of being up to date for screening. So some of those strongest predictors did include having visited a provider in the last year and actually asking for a test. But what we saw, especially with the work that I did, was that having a medical home, and in this case, having a primary care provider, was not itself by itself sufficient to improve the intent to get screened. So we looked at, of those patients that were eligible for screening, what was your intent to get screened? And if you have not been screened, were you intending to get screened in the next year or two? So of those that were not up to date with screening, just even though they had a source of primary care, most of those did not intend to get screened. So that proves that just having a primary care provider we can't just assume that that's enough. However, having a doctor recommend a test, if you went and had a doctor recommend a test, did help with that intention to get screened. Other things that helped were knowing somebody who got tested, and this really helped shape the intervention that they did, where they actually had members of the community participate and actually make flyers and posters and do service announcements, things like describing their experience getting tested and encouraging people to get tested. And we saw that really bumped up intention to get tested. Having a family history of cancer was a predictor of being up to date and intending to get screened, which is not terribly surprising, but I think that's a good sign. And then as far as health beliefs, the belief that screening does give one a sense of control over their health. So what we looked at here was, it's one thing to just know about colon cancer and know what it is, but education isn't really enough by itself. You really have to feel like you can be doing something proactively to prevent colon cancer. Of course, what we saw here, and I think this is not a surprise to many people, but that financial concerns were a significant barrier to getting screened or intending to get screened. And what was interesting is this seemed to be true not only for procedures that required a hospital or office visit, like getting a colonoscopy or a sigmoidoscopy, but even for things like a fecal occult blood test, which you would think would be much less expensive. So financial concerns were still a significant barrier. And I think that has to do with the fact that if you screen positive, you then do have to have some workup involved in that. Some people may have high deductible insurance plans also. What we saw also, you were talking, Mike, about the zip codes and geography. What we saw here was that proximity, living close to a facility that does screening procedures like colonoscopy in a surgery center, is not necessarily a factor. You would think that it might be, but that just shows that there's multiple layers to this. From there, I also did later work, and this work was more focused on survivorship, but I'm going to mention it here because the work I did in the San Luis Valley, which is highlighted here in red, for those of you not familiar with Colorado, this community in southern Colorado is an intermountain rural community. So it's geographically distinct, also medically underserved. And again, those blue and green areas are considered frontier or rural counties, and the lighter green areas there would be the Front Range, Denver, Aurora, Boulder, Colorado Springs, etc. So there's quite a big distance from the major metropolitan areas. And I did some work just after doing that work, looking at screening, looking at survivorship in another rural community. So in other words, what does it look like for people living in these communities? And thinking about survivorship, if you've not heard that term, someone who is a survivor of colorectal cancer, that begins at the time of diagnosis. So from the minute you're starting that workup and diagnosed with cancer, what has been your experience from that point forward through the course of your life until the time of death, whether it's from colon cancer or other causes. And this was qualitative work in that San Luis Valley. It's a distinct rural area, even though it is rural. I think one of the biggest lessons is that rural areas are not all alike. And I definitely learned that here. It's distinct historically and culturally from that High Plains Research Network in Eastern Colorado. We used a boot camp translation project, and that's just a methodology that helps us really get engaged. Again, here we used a community advisory council and partnered with them, and they really helped to interpret some of our findings and come up with the process that we were going to use. Again, I had a family medicine mentor, and I bring that up just to say that where I live in the academic world, I'm a general internist, and I kind of have the luxury of being at a center where we have specialists and subspecialists for everything you could think of just about. In these rural communities, we are really dependent upon largely family medicine physicians and nurses and public health professionals, behavioral health professionals even. So again, I partnered with them here because most of the providers here were family medicine providers. And again, we explored themes around what happens after a cancer diagnosis, but that conversation really kind of took a turn, and a lot of it was around that diagnostic process. So I thought I'd include it here. The lessons I learned from this work, building upon what I learned before. So this geographically defined region, remember I said it was an intermountain valley. So it was kind of like a basin, if you will, surrounded by mountains on all sides. But because it was a geographically defined region, there were 6 counties here. And just being in that region doesn't necessarily mean that the healthcare systems or clinics there are all integrated. There were 3 very distinct healthcare systems. So you can't assume in a rural area that one system does things the same way that the other system does, or that they're interchangeable. A high turnover of medical providers and staff is a given, and I think that definitely impacts anyone who's lived in this area. And some of the comments that I got in doing this work were, for example, going to the ER, you know, you may have a different person if you need to go, even for primary care. ER providers turned around quite frequently as well. Once again, financial barriers were a direct and indirect barrier to getting care. And I mentioned this just to say that, you know, insurance is an obvious one, the socioeconomic status. We know in rural communities that there's higher incidences of poverty, being medically underserved or underinsured. But also thinking about things like when you're getting a colonoscopy, for example, that involves transportation, and it's not just any transportation. You can't just catch a taxi. You really need to have a chaperone and plan to take that day away. If you then need to leave that community to go for treatment, and this was definitely true in the San Luis Valley, in some cases, you'd have to take time away from work, arrange for childcare. What does this also mean? And there's a term now that I've become familiar with called financial toxicity. So what are the financial costs and the toxicity around the process of getting screened and treated? In this community, primary care providers, having said that, were definitely noted to be a strength. And when I interviewed the oncologists, a lot of them said, you know, one thing I do note about rural providers and practices is they seem to really take on a lot more and be willing to take a lot more responsibility. But having said that, there was definitely a lack of cancer-specific resources. A big theme was this theme about a black hole of information transfer. So once someone is diagnosed or going through that process, just the black hole of information between specialists and primary care providers. And it was a pretty common scenario that I heard specialists say, you know, I send notes over to the primary care provider's office and then I never hear anything back. And the primary care providers would say, you know, I send patients to the specialists and I never hear anything back. And that was a theme that came up with patients as well. They were quite anxious about, you know, going to their primary care provider or to the specialist. Do you have all the information from my primary care provider or specialist? There was noted some stigma and fear around screening and diagnosis. And by this, I mean, you know, there was a little bit of this belief that if I get screened, is that going to make me like more susceptible to cancer? Or if I bring up the topic of screening, I'm kind of inviting cancer in. And then there was also a little bit of stigma that, you know, if you live in this rural community, you would automatically have to go elsewhere if you were diagnosed with cancer to get your treatment. Some of the themes here, and I just include a picture in the background, this was how we worked a lot of the times, was these group meetings very informally. But cancer is a trigger for changes in relationships with others in the community, with your providers, but also with yourself. Information is important in the community, but it really needs to be tailored and made meaningful to all users. So what does it mean in this particular community? How can we translate those messages? Resources that are available should not be one size fits all, and they often are not. Logistical and practical barriers, so I mentioned transportation, that was a huge one, are ever present in rural communities. How do we promote a sense of volunteerism and community support? So that was a big theme in this community, is what can we be doing as a lot of these community members were lay people, some of them were medical professionals, but a lot of them had their own careers that were not in medicine. But how can we really promote a sense to help each other out, not just by money or donating, but with time and support? The big theme, and I'll say this as a blanket statement overall in my work with survivorship especially, it's really important for people to know what to expect next. So what's next if I have a positive test, what is next? If I have a diagnosis, what is next? Once I finish treatment, what is next? People may begin to lose confidence in what is normal versus what is abnormal. And spiritual influences were highly acknowledged. So I'll leave with some of the, I think some of the current issues to maybe think about as we continue our discussion, and some opportunities. And thinking about this last year in particular and how we might interpret this research differently and moving forward. So one of the biggest changes to practice I've noticed as a practicing primary care provider, telehealth is definitely here to stay. It's a good thing. It's definitely found its place and helped us in the last year. But moving forward, does this have the potential to improve disparities or to actually worsen disparities? So thinking about my dad, for example, he wouldn't be able to navigate a telehealth appointment by himself. He would need help to do that. How do we do telehealth for people who don't speak English, for example, or who don't have internet access or computers? We've seen that situation in some of our schools over the last year. There is an increasing menu of colorectal cancer screening options, and I've noticed this anecdotally. Whether it's an impact, I don't know that we can say for sure about people not wanting to come in to get colonoscopies or sigmoidoscopies. I say we do far more colonoscopies, but a lot more people are now asking for stool-based testing. So you've all probably heard about Cologuard and the fecal occult blood test. These are things you can do at home. There's an increasing recognition, I know in our practice, about team-based approaches. So how can we really utilize a medical team to make sure that people are getting recommended preventative care, and for proactive outreach? So actually not just depending on that medical visit. Remember, a lot of people who have a medical home are still not up to date. So how can we proactively outreach and catch people who are not up to date and have a conversation with them about, hey, you may want to think about this before your next visit, or even get it done before your next visit. How can we utilize team members, patient navigators, for example? That's a strength here in Colorado. And then lastly, our electronic medical records. There's been a huge transformation since I started practice over 20 years ago. The electronic medical record capabilities have come such a long way. They're not perfect. I mentioned this black hole of information transfer, but how can we utilize those electronic medical records to share information so that pieces don't get missed, so that we know when someone gets a screening test through a community event, for example, and how can we then make sure that they're keeping up to date with their screenings. And with that, I'm going to leave it. There's my email address if anyone wants to reach out to me. And I think at this point, Mike and Reese and Kelly, I'm going to go ahead and stop sharing if that's okay.
Yeah, that works. There we go. Thank you so much for that presentation, Dr. Overholser. Lots of really important information in there, lots of different ways that we can address from both the medical community standpoint and what the survivors and caregivers out there can look to, and how to engage their care team in the process of healing and survivorship. So thank you so much for all of that. We'll see. Let me just check to see if there's anything in the Q&A. Please remember, if you want to ask any questions, just go ahead and drop them in the Q&A chat box there, and we'll be happy to get the answers for you. Next up, we have Kellie Hoffman, who is a research advocate, having lived in West Virginia and been a caregiver for her mother. She has a really important story to tell that will help put all of this into context for you. So let me just go ahead and pull up her presentation, because I'll be running it for her. And then Kellie, you'll be able to take it away. Just give me one moment.
Thanks, Mike. I appreciate it. Well, this is my mom's story, and it does involve me. I was an only child. I was her only caregiver for 9 years. And I always talk about her, but I never really get to show her a picture. So this way you kind of get to see her. You can change. That's my mom, Linda Sue Crump. She lived from 1952 to 2014. I will try not to cry the whole time. She was diagnosed with stage 4 colon cancer in 2005. She had to have radiation, chemo, and surgery. She would have a colostomy bag for the rest of her life. And like Dr. Overholser told us, my mom's oncologist did leave in the middle of her treatment. And it was really shocking to her. And I believe his name was Dr. DiStefano. And he called us in, and we had to meet in his office. It was totally different from a usual appointment. And he called us in. He's in a suit and had us in, behind his big desk in his office, and told her, and she was upset. It did throw her off. She was really attached to him, and then he left in the middle of her treatments. But during that time, the very first time, she was able to have all of her procedures done here, which was really helpful. She would have her chemo done at St. Mary's, or we had a place called HIMG. It was Huntington Internal Medicine Group, and she could have them done there. And then her surgery was done at St. Mary's. You can change for me, Mike. And then again, her cancer came back in 2009. It was in her liver this time. And she was told she could not have her surgery here. And that upset her a lot. She was not happy. And it really, I don't know, she kind of got angry about it too. And she was like, what do you mean you can't do my surgery here? So they suggested she go to Duke or UK. They really pushed Duke. And I don't know if the doctors were friends, if they knew Dr. Clary at Duke or how that went. But we did end up at Duke. And she did have to have a third of her liver out. I wanted to show this map. And Dr. Overholser made a good statement too about having to have a car. And I didn't think of that until she mentioned that. But that is true. A lot of my friends here don't own a vehicle. They do take public transportation. But thankfully we did. And I was the one that took her as all by myself. My husband had just died a couple weeks before. And I believe I took the route that would have involved the toll booth. So I probably took the one that was in blue to get to Duke, and took the toll road down through Beckley. And my mom did let them keep her liver for research. They took us into a little room and asked her if she would be all right with that. She's like, yeah, that's fine, as long as it's not in me anymore. You can change, Mike. That was mom in her wig. Her cancer came back in 2014, and it was all through her. And she was always so proud, because her chemo, she had never lost her hair, but this time when she was going to lose her hair, so she bought her a wig, and she looked so good in it, and she wore it. That's the only picture I have of her. I think I still have the wig. But I just want everybody to see her. You can change. She did lose her hair a little bit. This is Hospice House. This is Imogene Dolan Hospice House. It is in Huntington. This was around, I believe, April, probably mid-April 2014. She did go through a round of chemo. and it pretty much did her in. She had the chemo on a Friday night, ended up in ICU on a Sunday night, and then she denied any more treatment. They were wanting her to do dialysis, and she refused. So then everything fell on me, and I wanted to get her to Hospice House. And they made me wait for 24 hours before I could move her. Finally, at the point I did get her to Hospice House, the staff finally, they were the only folks during the whole 9 years that looked at me and said that they were there as much for me as for her. And nobody had ever told me that the whole time. And so it was very reassuring. They did a really good job. And it was so nice to get her out of the ICU and somewhere where I didn't always have to hear, all the intercoms and all the machines going off and all that. You can change This is our current situation here in the Huntington area. We are now a monopoly, and we only have one choice for our healthcare. There are they're separate facilities, but now they're all one. It was St. Mary's Cabell Huntington Hospital and HIMG, the Huntington Internal Medicine Group. And a couple years back, Mountain Health Network decided to buy St. Mary's, which was our Catholic nonprofit. And there was a big fight, and I believe St. Mary's had to get approval from the Vatican. And it was all finally approved. So now we have a monopoly here, which I guess it's better. That's kind of my point too. Cabell Huntington is one of the 10 largest hospitals here in West Virginia. And St. Mary's is the second largest in the tri-state region. They consider us the tri-state region. We are very close to Ohio and Kentucky. I can be in Ohio in probably 20 minutes, in Kentucky in a half hour. I believe King's Daughters and Ashland is the largest in our region. But we are kind of a hub. So I grew up in Mason County, and our only hospital there is Pleasant Valley Hospital. I believe they are also owned by this network at this point. So mostly if there's an accident, a car wreck, a four-wheeler wreck, whatever it might be, they are flown here. So we are more a hub. And so we also have a couple of little, I see a place called Valley Health where we have primary care doctors and such to go to as well. You can change for me, Mike. So having to watch my mom battle colon cancer for 9 years definitely made me change my habits. I've decided to eat healthier, and I have become a certified wellness coach. I'm getting ready to start my 600-hour training next week. I'm not really ready for that. It is in Ayurveda. So my kids now use ghee when they cook. I have tried to get them very aware of how high risk they are for colon cancer. And I am extremely high risk. And I did just recently had to fight to get my colonoscopy. I am not the 10-year program. I am the 5-year. And I had my first one after my mom died. She died in April of 2014. I had my first colonoscopy in October 2014. And I remember going to my follow-up, and the surgeon told me, well, he'd see me in 10 years. And I'm like, no, you won't see me in 10 years. And I went to my primary doc, and I said, well, he said I'm on the 10-year plan. And she's like, oh, yeah, you are. I'm like, no. So I had to find out new primary doc. And thankfully, Dr. Dillon, I see now, I'm like, listen, I need my colonoscopy. I'm late. And she referred me to a gastro. Thankfully, his nurse called me, and she was like, he says you don't need to come to this appointment. You need scoped. And I'm like, I do. So it was such a relief to find a doctor that does know I'm on the 5-year plan. I actually ended up being a year late because of trying to get all that sorted through, but I did have my colonoscopy this past October. You can change mine. Or am I done?
That is
That's it? Cool, then I am done.
Final thoughts you want to share there before we go?
I don't think so, but if anyone has any questions, I'll try to answer.
Certainly. Well, Kellie, thank you so much for feeling comfortable.
Go wipe my nose. I hope nobody minds.
Absolutely. Do what you need to do if you need a tissue or anything like that. We understand that these are, this is your story, and this story has a lot of power, and with that power comes a lot of emotion and everything. So I hope that we are able to honor your story through this resource and through the work that we do with you, outside of this and what you do with Fight CRC, because we just want to show gratitude to you for feeling comfortable.
Well, thank you.
A lot of other people can benefit from it. So thank you. Let me check the questions again, please. If there's any other questions, have them in the chat here. I know that there's been a few questions that have come into us through our community leading up to this that, I think were covered in a lot of ways already, which is good, but just giving a chance for both Kellie and Dr. Overholser to perhaps elaborate on some of them is always helpful as well. So let me go ahead and get those questions up, and we can have you both answer it. Either one of you can answer whichever you feel. You can just go ahead and jump in if you've got something to say. So one of the things we talked about is the uniqueness of these different rural communities, both, the communities that Dr. Overholser has worked with and where Kellie lives have two very different aspects to them. And certainly transportation is a big one of those. And we know that's a really serious thing to address. So do you know of any specific resources that are out there that, a patient navigator or someone would know that maybe isn't a traditional resource, like just a state-funded transportation system, but if there's sometimes like online meetup groups that do that kind of, carpooling or something along those lines, other assistance resources that can help with one of those huge barriers?
Yeah, so I can, it did come up in the work I did more in the San Luis Valley. So as an example, if someone was going through treatment or any medical situation and they would need emergency care that they couldn't, they need to be transferred out of the valley, I found out that it is a staggering cost to be life flighted out of the valley. I think the number I heard was like $30,000. It was staggering to me. And I'm honestly surprised that, I think looking at transportation issues would be a really needed area to research because it is so prevalent. I mean, even in the Denver metro area, it's just hard to make arrangements for transportation. So unfortunately, it is something that is lacking. I have found that, certainly resources like the American Cancer Society does help people with transportation. And that's what a lot of people relied on in the Valley, were programs like that. However, there are limitations. And I think particularly for survivorship. So if someone is a survivor and they're not actively being treated for cancer, but they may have complications related to their treatment, or they need, that ongoing follow-up out of the area, that was kind of a little bit of a gap. So I did work closely with the American Cancer Society to look at some of those things in the San Luis Valley. There is one organization, I think it's specific to Colorado though. I think it's called Angel Flight. And they will help bring people like from the mountain communities, for example, to more urban treatment centers, for example, and they do that through some private fundraising that they're able to stay afloat. But it is a gap. It is a real gap. And unfortunately, patient navigators can help find resources. But again, thinking about something like screening, like you really have to have the chaperone, and a lot of taxis. I've even I remember in one case, we were trying to see if the Rotary Club, the local Rotary Club, would have volunteers that would be able to provide transportation.
Sure, yeah. Sometimes it's those outside the box thinking that gets the job done. Kellie, have you heard of anything like that, or any other, even maybe perhaps like just peer support for colorectal cancer that may be unique to rural communities, or at least available to them?
No, I know here we do have ACS and they help. You know, they have the drivers, the volunteers help pick people up. But besides that, we were very lucky. And my mom was so stubborn and independent that she would drive herself to radiation. So unless she absolutely needed me, she didn't want me there. So we were lucky. But I do have, you know, I know people here in the area that don't have transportation. So, but we do have buses and we do have taxis. We do not have many Ubers. So that's not something that's very, very big in this area.
Sure. So yeah, finding different things. It looks like Debbie has put in the chat there that Medicaid has a transportation offering in Oklahoma. So if any of you out there from Oklahoma, you can look into that as well. And I'm sure many other states have that. I know in Rhode Island, we have that here. So there's different options for different people in different areas, and looking into those is certainly important as you look to close that gap in that barrier, certainly. And then as far as, you know, looking at where some of that, you talked a little bit in your presentation, Dr. Overholser, about, you know, stigma that exists and the way people talk about screening and people talk about what that could possibly mean. And there's a lot of misinformation out there. There's a lot of misinformation out there about all sorts of medical conditions, you know, and you hear different things in different communities, you know, and we found as we've done this health equity series of webinars that a lot of times the sources of that stigma and also the sources of the appropriate information can differ greatly between different communities. So I was wondering if you could, either one of you could elaborate a little bit more on maybe where some of that misinformation is coming from in the rural communities that you've worked with, and what sources of truth may exist for helping to access trusted information specifically tailored for those communities.
Yeah, so I didn't know if Kellie wanted to answer this. I don't want to kind of usurp the conversation. But I think, you know, when I say stigma, I think, you know, to a certain extent, I think some of that comes from, my sense was, and this wasn't something I really had an opportunity to explore more deeply, but I think there's a little bit of component of, you know, some trust issues. But I think you know, when I was talking to people and doing these focus groups and interviews, it's really just kind of word of mouth and like, you know, this has been our experience, and it just gets passed around through word of mouth that the stigma was, you know, oh, if you get diagnosed, you're going to have to go out of the valley to get treated, because there were certain things like radiation that they just could not do in the valley. And so I think, and the other, when I say stigma, it was once someone's diagnosed, and I'll never forget this quote, but someone says, you know, once you hear the C word, you automatically think of the D word. So once you hear a diagnosis of cancer, you automatically think perhaps of death. And, you know, we have come a long way with treatments, and that isn't always the case. So that's kind of a barrier for survivorship issues, I think, as well. So I do think some of it, I mean, there's probably complex issues related to trust and just a person's experience, certainly cultural competency, right? I mean, I mentioned in Northeastern Colorado, when Dr. Westfall's team did the intervention for screening, it was really important. You know, the community said, keep in mind, we need some Spanish language versions of whatever you do. I think what we found in the San Luis Valley was that having a source of trusted information was very important. And I think in that situation, people really looked to their providers. So here's what we see on the news. Here's what we see the National Cancer Institute. There's, you know, National Cancer Institute, American Cancer Society, great sources of information, but it doesn't really speak to like what's going on locally. So tying back to that transportation conversation, for example. So it really is a big burden on local public health, I think, and local providers to make sure that they're a source of good, reliable information.
Certainly. Kellie, do you have anything to add to that?
Yeah, I agree totally, because here in my area, you know, some folks go all the way to Cleveland for treatment, or Cincinnati, Columbus. Columbus is actually closer in Cincinnati. We're only like 2 hours Columbus. So a lot of folks get sent, to OSU. They also get sent to UK and Lexington. So, but I agree too, the local, I think too, just having someone go through it, and at least if they will talk about it. It's like my husband, he knows I went through it and his family has went through it, and he still won't go and get his colonoscopy. So I don't know how you reach people like that, but just folks, here churches are so big, and they can't really gather yet, but hopefully when they can, to have people, and that's how we find doctors too, it's word of mouth, because I went without a primary for way too long. And a friend of mine came up, she's like, I like this doc, you need to go see her. So I gave her a shot, and now me and my daughter both go see her. So I think that, in this type of area where, word of mouth definitely is the way to go. And with, whatever type, my kids were both in band. So, you're going to be talking to other band parents or football parents, and that is how we find out about such things.
Sure, great.
And I think the other thing that I'll just to tag on to what Kellie was saying too, I think to extend that further is, this whole information about the information black hole, that's an area that's really important to me. And I think it is important through this process to have consistent messaging. So is a person and a caregiver getting the same information from their oncologist, their cardiologist, or whoever they're seeing as they are from their primary care provider? And that's what I'm trying to advocate for, primary care being involved, but it's really important to have consistent messaging too.
Certainly, yeah. And as a former community health worker and patient navigator myself, I certainly always stress the importance of that role on the care team and their ability to be that glue to connect those things together. So certainly see if that is available in your primary care practice or patient-centered medical home out there for all of you. And then before, I have a couple more questions, but I've seen a couple things come in the chat that I want to make sure I outline for all of you. So it looks like Gloria has said that in Lower Arkansas Valley, they use IntelliRide, which is a Medicaid transportation for non-emergent transport. And then Aaron has provided a link to a rural transit assistance program, the state directory for managers. So there's also a phone number and looks like an email on there as well through www.cancer.org. So open up the chat in the bottom and check that out for some resources there as well. Thank you so much for adding those in. And then so really just looking at one more thing that I know is really important that Kellie had talked about at the end of her presentation. So I'll put to you first. You talked about in so many ways, you didn't get what you needed the first time around, and you needed to advocate for those particular aspects of care for your mother and for yourself in some ways, and the resources you need as a caregiver for her. By the end, you'd become a pro at it and really knew what you needed to do. But that comes from experience, and it comes from not being sure whether you're in an appropriate position to do so or what have you. So what kind of maybe advice or tips or just words of encouragement perhaps for people out there to really understand that advocating is okay and important and often a necessary part of the process to really put yourself in a position to get the care that you need and deserve?
Yeah, it's definitely necessary. And I know a lot of people aren't me, and a lot of people aren't gonna feel comfortable sticking up for themselves. My mom did too, and I'll tell this real quick. For my mom had her colostomy bag when we were at Duke, they were a teaching hospital. And so Dr. Clary came in once during the weekend. He had all these residents with him, and they were all wanting to see her bag. And she was my mom was blunt. We're both blunt, so I guess that helps in that process of being your own advocate. But she's like, listen, me and my bag get along just fine, all right? She was just like, no, I've had enough. You put me, you're proud of me. And you do have to be that way, and it's all right. And sometimes I think they need to learn to back off, and sometimes they need to learn to give you some more information, because at the end, it was like, I would have to hunt her doctors down in the hall outside the ICU room. No one ever sat me down and explained what was going on or why things had happened. No one ever asked either of us if we needed to see a therapist or any mental health. No one ever said, what do you two need? Even when she was diagnosed, they had told her during the colonoscopy, when she was all woozy, that she probably had colon cancer. So, we're in this room with all these strangers. The only things between us are thin little curtains, and she's still pretty much high going, they think I have colon cancer, Kellie. And it's like, why did they tell you? Why did they not wait and, take us privately to a room or something instead of just telling you around all these people? But it is hard to stand up for yourself, and you don't know, and you hope someone will give you some answers, but you just have to, because nobody's going to do it. And like I told my husband, the only thing they can really tell you is no. And that's not, that's not absolutely horrible to be told no. And it's like, all right, so I'll try somewhere else or a different doctor.
Certainly. Dr. Overholser, do you have, being on the other side often as the provider, I'm sure, do you have any advice for survivors and caregivers out there on how to communicate their needs effectively to providers?
Yeah, well, first of all, I just want to thank Kellie. I haven't had a chance to say it yet, but thank you so much for sharing your story. And your mom sounds wonderful, and thank you for sharing her experience. And as a caregiver, I think it really is important to realize the role of the caregiver and the stress that they go through. And I guess, I think it's, I am a provider. I'm also a patient, right? So I think there's a tendency to kind of get intimidated, especially with the specialists. But I agree. Sometimes you just have to kind of speak up. I think that's where, in my role, I never want to make assumptions about where somebody is. So there has been a recognition to try to be more proactive about, how are you doing? There's this thing called the distress thermometer and similar measures like that to really realize the psychosocial impact of things. So again, I think that for my part, what can I do? It is certainly encouraging people to ask questions. I think at the end of the day, we just have to ask, do you have any questions? Sit them down. It's interesting that you bring up that experience, Kellie, about the situation when she was told that she had colon cancer, and you specifically mentioned like the thin curtains and everything. That was I remember this when I was doing this work in the San Luis Valley. It was the same type of thing with breast cancer screening. Like, you're in this room there's a curtain around and someone comes in and discusses like, there's this abnormality, we want to do more imaging, and, can it be a little more private? And I think, we certainly, those are the resources that were available, but based on that work, they did make some changes with that workflow. So I was happy to see that. But, I think as a provider, sometimes we don't think about like the day-to-day, like what the impact is on patients. So I think it is just so helpful to have that feedback, the importance of having community representation on things that are happening in the hospitals and our medical centers, in research projects for that matter. For anyone who's doing research, is look for opportunities to get involved with research projects. And, in the High Plains Research Network, they have a long history of that. They were involved from the very beginning, and it really shaped the intervention that they came out with. So, I think there's a lot more to say, but just really recognizing the psychosocial impact. And like I said, people really need to know what to expect next. That was a big lesson that I learned as a primary care provider. One of the big lessons I learned was survivorship, and I apologize, I know we're running a little short on time. But probably the biggest lesson I learned was, when someone finishes their active treatment and they're now being, told by the oncologist, we don't need to see you so frequently. So maybe you come back in 6 months instead of 3, or, you're done with treatment, go back to your primary care provider. I didn't realize that is a really anxiety provoking time for a lot of people. And so just knowing that, I think, can change how we practice. So I just wanted to share that.
Thank you so much. We all appreciate that input, certainly, and we can use that in our resources and use that in everything we do moving forward. So we are getting close to our time, but I did want to give you both the opportunity to have one last final word, final sentence on, what people who are here in attendance or who are watching this webinar recording later, if you want to take action and help support members in your rural community to gain better access to screening and treatment, what final words of advice or encouragement do you have on how you can take action moving forward?
So for me, I think I would just reiterate maybe that last point about, look for opportunities to get involved. I think a lot of medical facilities now anyway are recognize the importance of the impact on their communities. So if there's opportunities to get involved on community advisory panels, people doing research, I think, organizations like the American Cancer Society and the National Cancer Institute. I think the American Cancer Society has a little more network of people kind of on the ground in local communities. But, just get involved. And I'd say I guess I just would say that there's a lot of really exciting things that I couldn't even envision that would be done, right? That could be really cool resources for people in the community. I've seen examples in the High Plains Research Network. I could share stories, but I know we're limited on time, but just how, if you give people the opportunity to kind of become their local experts, the answer may not lie with me, right? It may be somewhere in the community. So just never underestimate the power that someone in the community has.
Indeed. Kellie?
I just want to let everyone know to just educate yourselves. With me, I'm exceedingly high risk. I have to know that. I have to stay on top of all of this and know, that I'm on the 5-year plan and not the 10-year plan. And I also have to stand up for myself. And I hope everyone else out there will do that and, reach out to people and talk to other people and find out what doctors they like and, go from there, because just because someone likes a certain doc doesn't mean that you will. So you have to go and give it a chance. I think sometimes too, people are a little afraid to change doctors or go and get another opinion, and that's okay too. That's your right. If you're not comfortable with a certain doc, it's all right to get rid of your doc and get you a new one. That's perfectly acceptable. And don't feel bad about it. You got to do what's best for you and educate yourself and stay on top of all this. It's so changing with colon cancer. We're learning all kinds of stuff. So hang in there.
Absolutely. Well, we appreciate you sharing your courage, your strength, your emotions, and everything in between with us.
Thank you.
We're coming to the conclusion here in just a second. I want to make sure that I'm thanking Dr. Overholser and Kellie for being with us here today. And also thank you so much to all of you out there in attendance and all of you out there in the future who will be watching this as well. Also, this is March, so it's Colorectal Cancer Awareness Month. So I want to thank our sponsors for our Colorectal Cancer Awareness Month campaigns, which include No Shave November, Genentech, Lilly Oncology, CGen, Natera, Merck, Taiho Oncology, Exact Sciences, and Daiichi Sankyo. Thank you so much. Thank you to all of you, and we'll hope you see you next time, okay? Take care.